Dr. Persing. So he received his undergraduate degree and medical degree at University of South Dakota, completed residency and fellowship, hematology oncology, University of Mississippi. He was an assistant professor and the program director at USA, University of South Alabama, Mitchell Cancer Institute, and then also was Division of Hematology Oncology there. So very happy to have him as a speaker talking on sarcoma.
So I was really excited. I ran into Dr. Trent at ASCO again. He said, come back and do another talk. And so I did a precision medicine talk last year. And I think I was late getting back to him. And I was like, hey, what do you want to talk on? He's like, sarcoma. And I was like, do you hate me? So sarcoma is not my area of expertise, but like anything, when we jump in and start doing, when we start researching and looking at things, you realize even in sarcomas how much has changed. Sarcoma is difficult though, right? And why? Well, a lot of trials that have been done over years include multiple different types of sarcomas, and as a result, you're looking at a lot of heterogeneity within a tumor type, and you're trying to apply the same therapeutic intervention to multiple different types of cancer. And we know that when I was a fellow, 16 plus years ago, carbotaxol was actually the answer for just about anything that a patient had. And that's just because we didn't have other effective therapies at the time. And what we're learning in sarcoma, and we'll talk about this a little bit, is we're seeing more and more classification change that allow us to put patients in the right category. And so why is sarcoma so hard? So just the NCCN, there's bone sarcoma, Kaposi sarcoma, dermatofibrous sarcoma, and gastrointestinal stromal tumors are the main topics, okay? But on the right side there, when you go to click on your link to get to the algorithm, on the right side, that's the soft tissue sarcoma. Oh, but it's, so you start saying, gosh, I wonder why I don't know that. And all of a sudden you start realizing these are all the different types of sarcomas that are out there with soft tissue, not making fun of melanoma, but melanoma is melanoma. You know what I'm saying? And there's BRAF wild type, and then there's So I think as we think through that a little bit, that's some of the complication, and then we start looking at soft tissue sarcomas, and then this goes into even greater detail on those, and you just start saying, wow. And then you say, okay, well, that's enough. We know about soft tissue, but then we start saying, well, what about staging? And you have staging for ones that pop up in head and neck, and they're all different. If you look at them, all different tumor sizes based on where they are. So you can't even, you just have to go into the staging matrix and just start plugging in size and making sure that you're going down the right path, because you have extremities, head and neck, abdomen and thoracic, and then even retroperitoneum. Right. And so we start looking at this just thinking this is a lot of information, and this is just soft tissue sarcomas. This doesn't include bone. And so we start thinking, oh man, this is a lot. And then the modern medicine side of this, right? We're finally getting into classification with these sarcomas that allow us to make the right diagnosis. And so instead of having something that looks like an osteosarcoma, it may actually be, and I had this happen, a poorly differentiated pleomorphic sarcoma, and when that was reviewed at a larger center. And so I'll bring up a little bit of data presented at ASCO this last year from Brazil that looks at concordance, okay? And I think this is important. But look at all of these molecular studies that we're doing now to help categorize and make a diagnosis. This is making a difference, right? So we're actually understanding it. So I'm not going to do this too long, but since I have Dr. Titus here, I'm going to pick on him a little bit. He was one of my fellows before I left South. And so as I started reading about sarcoma, I'm like, why do I not know about this? I have a good feeling for epithelial malignancies. I even understand, liquid-based tumors, so lymphomas and myeloid tumors. Why don't I understand sarcomas? And I think a lot of that really stems from I'm going to say I'm not an embryologist either, okay? But it all starts with those stem cells, right? And start looking at mesenchymal stem cells, and they're starting to actually look at the microenvironment in some of these sarcomas, realizing because cartilage isn't supposed to grow. Once we have it, it's only supposed to repair. Muscles, we don't get more muscle. They hypertrophy, right? So we don't get more muscle. And so when you start looking at some of these sarcomas that are arising, why are they happening when they're happening in cells that aren't supposed to be dividing? And some of that's driven by the microenvironment, and some of that's driven by the maturation of these cells as they go through. And so there's actually some interesting reverse feedback mechanisms that may be happening as a result of inflammation. And one of those actually talks a little bit about Kaposi sarcomas, obviously associated with, herpes virus infections, right? And so we always think about lymphomas having a trigger like malt lymphomas, and we think about Epstein-Barr triggering certain tumors. And this may be some additional data looking at sarcomas developing from chronic inflammation or chronic infections, right? And so this kind of goes along that multi-hit hypothesis as well. We always talked about the race car that had the gas pedal stuck down, and that was your oncogene, and then you had the brake that was broken, which was your tumor suppressor gene, and all that kind of stuff. And now I say we have the police that throw out spike strips. That's your immune checkpoint stuff, right? So we've got like all sorts of mechanisms that happen, and these are some of those mechanisms that we kind of start to think about with those mesenchymal stem cells. So the MSC is mesenchymal stem cells, and you can start to see those changes that happen in those mesenchymal stem cells that are responsible for repair. The interesting thing is in reading about it, and this article was a super fascinating article. I didn't go to sleep because I was sitting in a airport lounge while I was reading it, drinking lots of coffee, okay? But the fascinating thing is these mesenchymal stem cells have anti-angiogenic properties, but also angiogenic properties at the same time. And it has to do with the environment that they're in, how they recruit, or how they limit blood vessel production. And so this may be interesting because this may play a role, some of these mesenchymal stem cells that are not malignant, in other tumor types as well. All right. And this goes into some of the way that those cells interact and what we're seeing in that tumor microenvironment, right? And how those change and how we can actually see some feedback for a cancer progenitor for sarcoma feeding back into part of those stem cells. So pretty interesting stuff. I always love throwing an orthopedic slide in because it's not often I quote orthopedic studies, but I like this because it gave a really good idea, kind of that mesenchymal stem cell into osteogenesis, chondrogenesis, myogenesis, merostroma. And we don't think about that, but the merostroma is actually driven by mesenchymal stem cells, which I in reviewing the article, kind of reminded me of fellowship. And I was like, oh, wait, this is interesting. And I think we're seeing, as basic science expands, as we understand more, it makes things easier. And so I put this in as important principles in sarcoma care because I think everybody in this room probably already knows this information. But I kind of highlighted the parts that I think are probably most relevant. And the first step is multidisciplinary evaluation, okay? And especially practicing in a community setting, I just don't have that. And even at larger academic centers, many times we don't have that because we don't have people dedicated to sarcoma, okay? And that includes a pathologist. The second part of that is whenever I'm sending them to a center, sometimes I tell the patient it's best that they biopsy this at that center because of that second highlighted part on the left there. And that is, remember that we want to biopsy along a resection track so that we're not poking a needle somewhere and they're having to take out more tissue than what they were going to have to take out to begin with, right? I'll finish that up. So the other thing that I thought was interesting is making sure we're testing for, genetic predisposition to developing these sarcomas. We know that they may arise with hereditary processes. And last but not least, at the bottom of one of those, it does talk about fertility preservation because I have to remember in sarcoma, this may be affecting younger patients in general as well, okay? So this was the Brazilian study I kind of alluded to, and this has to do with kind of concordance at a large center versus what they saw from outside. And I thought some of the most interesting thing is they had complete concordance, meaning they agreed with the diagnosis and the grading system, and then they had partial concordance, which was just some of each, and then complete concordance or complete discordance where they didn't agree with any of it, right? And so when we even looked at something as simple as grading, right? If you look at grade 1, 23%, 21% of those, 21% were revised. 22% of grade 2s were revised, and grade 3, 86% had revisions of some sort. Not informed, they actually had a fair number of uninformed decisions where the outside center couldn't actually grade it. And when they got there, you can see that the number of non-informed grades dropped significantly when it was in the hands of a pathologist used to grading this, right? And so I think even if it's not a second opinion, even if it's a pathologic second opinion, to make sure you have the right tumor type, okay? The other thing that they looked at, and these are a little busy, but they looked at the 5 most common. and you'll start to notice that they had undifferentiated sarcoma in the smaller settings. There were more undifferentiated sarcomas once they got to the academic center, which I thought was kind of interesting. But I kind of think it speaks to us sometimes trying to make a diagnosis and trying to put a label on something when there may not be a label for that yet. And so at the bottom, a little more complex because they included all of the tumor type, all of the sarcoma tumor types that they evaluated. But this was the part that I thought was maybe most interesting, and it had to do with a diagram regarding initial pathology review and grade. And this was kind of where those grades landed. And so you can see the uninformed really landed on 20% of those, 25% of those patients were shifted to an actual grade. You'll notice a lot of those were probably grade 2, which I thought was also interesting because, like, when we can't make a decision, what do? We pick the middle. And so, I'm kind of thinking the pathologist's like, oh, it's not a grade 1 and it's not a grade 3, maybe it's a grade 2. And so, kind of fits with some of that anyway. Obviously, grade 3, a fair number of grade 3s as well, but kind of as we go through. So I knew that sarcoma was going to be slow. All right. And so I went ahead and I asked, ChatGPT, tell me about sarcoma, but I want it in a rap form. Okay. All right. And so I actually thought, and I'm not going to rap. So, we're live streaming and I don't want that showing up later in my life. But I think when we read through this and we start talking about how do we make sure patients are getting what they need, this is something where a patient can type in the same thing I typed in and actually get the same information, right? And then all of a sudden, as I was doing that, I realized I totally botched it because I'm at CAGLA. And I should have actually done Zydeco form, okay? So I changed it to Zydeco, and I didn't bring the, okay, I'm going to mispronounce it, the Frodiot? Frodior. Froittoir. That's the washboard. I didn't know it had an official name, right? So I was like, what is that? And they're like, this is it. So I didn't bring that either. But I think that there's something about some of this. And you look at it, I think it's fascinating that ChatGPT can put this together and give us some useful information, because really honestly it talks about staging, it talks about diagnosis, it talks about moleculars, it talks about clear margins, it talks about like all the things that we talk about, right? And so it's not hidden out there. And I think AI, we were talking earlier, how do general medical oncologists keep up with 40 tumor types, much less 40 sarcoma subtypes, right? AI will help with that, but we have to know where the data is coming from, and we have to know how it's been vetted, and we have to trust the source. And it's not always easy to do that, right? So, but I thought this was the first response, which I think is pretty impressive because it was actually a fair bit of fun. All right, so this one's going to kind of be a guess what I'm thinking. So historical perspectives. When I say Ewing sarcoma as a medical oncologist, and it talks about multi-agent chemotherapy, what do you think? Oh, come on. Vakai! Yay! Right? So that's like the only, like there are very few sarcomas where it's like when you say this tumor type, we say this response, right? So the only other one that I could feel really confident with, and I had to line it out here, was giant cell tumor of the bone. What's that one? Yeah. Right? And so, I think there are those things where we just say, okay, we know how to handle this. This is what we do as medical oncologists. But the challenge is, this is part of a multidisciplinary team. And so much of this needs to be discussed. And so probably about 2/3 of what we'll go through, and I want to make sure I don't go over, because I don't want to be up here more than 30 minutes talking about sarcoma anyway, is there was a great review article, and a lot of this article came from the ASCO abstracts and posters, and I think there's a lot of interesting information that's out there. This was the first article that when I was reading through that, kind of felt like gemcitabine taxotere is tolerated pretty well. When we have the 3-week schedule where we're doing the larger dose taxotere and then try to get the gemcitabine dose in on day 8, I always have issues with patients tolerating that. And that's always a question. Do I try to do gemcitabine 1 and then gemtaxotere, day 8, and then try to give growth factor support? What do I try to do to fix that problem? This was an interesting study looking at about a 50 milligram per meter squared dose of docetaxel every 14 days. as opposed to a 75 once every 3 weeks, with gemcitabine every other week. And I think we've kind of adopted some of that in like pancreatic with gemcitabine and Abraxane because we think it's kind of easier to tolerate. But the fascinating thing here, when we looked at the response rates, the 21-day regimen had a little lower response rate. And you wonder if that's we're not getting the dose intensity in, right? Because you shouldn't see with more chemo lower response rates. The interesting thing is it really didn't make a huge difference. And this was a small group, right? So we're only talking, I think it was, I'm going to tell you wrong. I think it was about 140, 150 people, give or take. Okay. So 75 in each arm. And so when you start looking at it, but the tolerance was so much better. And when you look at the peripheral neuropathy, about the same. But when you look at like anemia and thrombocytopenia and febrile neutropenia, you have a reduction, of 90% in febrile neutropenia. And these are the people we want to keep on therapy as best we can. And so I think this was an interesting way to do that. They looked kind of at that dosing. There were some patients, about 6, that got less than the 50 milligram per meter squared there. So you can kind of pull the 14-day schedule on the left, the 21 on the right. And so you can kind of see the differences there. And I think the interesting part of it is, while there wasn't a huge difference in our progression-free survival or in our overall survival, there was a trend in progression-free survival, meaning it's at least not inferior. Okay. I'm not saying everybody needs to switch to a 14-day schedule, but I think this is one of those ways that we can adapt our therapy to try to make it better tolerated for our patients. All right. Not a new perspective. Optimal chemotherapy. This has been studied about 1,000 different times. I thought I would just add one more layer on top of the cake to say that adriamycin and ifosfamide is still really superior in aggressive high-grade soft tissue sarcomas, right? And so you can see 5-year overall survival is superior and progression-free survival is superior. Obviously, toxicity is more as well. This was perioperative Adrian ifos versus gemtaxetere. So kind of thinking about that, delivered 3 cycles neoadjuvant, 2 cycles adjuvant, and it's just superior. And while it's harder to deliver, it is more effective, right? What about second-line treatment for soft tissue sarcoma? Looking at 3 separate drugs. So this was interesting. This was the Japanese group looking at pazopanib, looking at eribulin, and trabectedin. And the doses were all pretty similar to I think what we're using. So not any big differences. There were leiomyosarcs, liposarcs. And then 45 that had other, right? Which is what we see in all of our sarcoma trials, right? What I talked about at the beginning. We throw everybody on and all the benefit may be from like 2 patients. But when you look at progression-free survival, it was a little superior with pazopanib, overall survival superior, and disease control rate superior. And so I think this kind of speaks to our TKIs and some of these very broad spectrum TKIs. In fact, they're finding in sarcoma broad spectrum may be better than narrow TKIs just because it's targeting more of that microenvironment and more potential mutations as well. So that first drug, sitalimab, is actually a PD-1 inhibitor used in Asia. And so this was looking at adding that to doxorubicin and ifos as first-line treatment with undifferentiated pleomorphic or UPS synovial myxoid sarcoma or dedifferentiated liposarcs. The dosing there, when you look at the ADRI and the IFOS, I think that's pretty standard for what we do. They actually continued checkpoint inhibition for up to 2 years or unacceptable toxicity or progression, right? And so objective response rate was primary endpoint with progression-free survival, overall survival, and safety. And what they had 46 patients enrolled, which sounds like kind of small, but the objective response rate was pretty high at 68%. The interesting thing, there were a fair number of grade 3 and grade 4 events with the checkpoint inhibitor included. But when you start looking at folks with advanced disease, overall survival of almost 20 months is actually pretty good with some of these sarcomas. And so I think that checkpoint inhibitors have had some benefit in some certain tumor types, and we'll talk about one of those at the end. But right now, by themselves, really aren't showing the promise that we had hoped in sarcoma. And kind of moving on to looking at durvalumab and tremelimumab, compared to doxorubicin, and I put this in there because this is happening right now. It's not 32 out of 100 patients enrolled, so we don't have any data on this one. But I think this is one of those where we start to say, does enhancing checkpoint inhibition improve response, or are we going to see maybe suboptimal responses like we've seen with other checkpoint inhibitors single agent? This was a SARC 032 trial, surgery with or without pembrolizumab. So this was pembro delivered with radiation in the neoadjuvant fashion, and then up to 14 doses post surgery. Okay, and as you might expect, we had a little higher disease-free survival. We haven't reached grade 3 tumors with disease-free survival yet, meaning they probably fared better because they had more aggressive disease and had better responses to radiation and possibly immune therapy, because neither group has reached that yet. But when you looked at it, we had grade 3 toxicities that were significantly higher in the checkpoint inhibitor arm. Probably not a surprise. It'll be interesting to see where this lands over time with that disease-free survival. The other data points they were looking at hadn't been reported yet. So much like everything else now, right, everybody wants to get in on some bispecific therapy. And so there is a bispecific now approved. It's against MAGE-A4, and then also includes appropriate HLA type. So this is now approved. It was a SPEAR trial that did this, and we'll actually talk about that SPEAR trial. So this was a Lancet. This was April of last year. So this is not even a year old at this point in time. And like we said, it's the dual the targets are going to be MAGE-4, but then HLA antigen, and this is where all that HLA antigen that pops up on the third page of my current preferred molecular assay is important, because these are the patients that we can look at. The interesting thing about this trial, these patients had received median 3 previous lines of therapy, which is a pretty heavily pretreated sarcoma group, right? And you have a response rate there of 37%, which is actually pretty remarkable. They saw cytokine release in a lot of patients, but only one grade 3 event was identified. Saw some cytopenias, mainly lymphopenia, neutropenia, and leukopenia in almost everybody. Okay, but in general, you see response rates that high. This was their waterfall plot and then spider plot, and you can see some people had absolutely no response, progressive disease right from the get-go. Some people had pretty impressive responses. You can see at least 2 there that had near complete response of their tumor. One of those really early, one of those about 64 weeks in, but you can see some durable responses happening in those early responders as well. So I always love a good spider plot. They're just kind of fun to look at. But you can see, you can't do that with big trials because you can't put that many patients on. But kind of fun to look at those and say, gosh, this may be an option for some of those people with round myxoid or advanced synovial sarcomas. So we can go into, I put tyrosine kinase inhibitors, but I also put pills on here now, right? Because there's some other classes that aren't really truly TKIs anymore, okay? Temezostat, I'm gonna murder. If there's any rep from the company, don't take it personally if I destroy your drug name. I don't use it every day, right? But it's easier to do the trade name anyway. But temezostat. Anyway, all right. Anyway, so this is approved in metastatic epithelioid sarcomas, 800 twice a day. Objective response rate was primary endpoint. They in enrolling, it was kind of basket trials. 9 of 62 patients had an objective response. 16, so 26% had disease control at 32 weeks. Median progression-free survival 5 months. Median overall survival 19. And so what do we see with it? Anemia, weight loss. And I think this starts to come into some of the challenges that we have in general medical oncology too, and that is we might use this drug once or twice during our career. How do we get educated on this medication? How do we make sure we're monitoring for the right toxicities? How do we learn that? And we're going to have to take the responsibility and read, I guess, have to go back to package inserts. I haven't seen a PDR in a while, so don't pull out the PDR, just go online. So other things that happened, they did have seizure and hemoptysis in one patient each. And so obviously when we're looking at smaller groups, we may not have seen all the side effects at this point in time either. So nirogacestat, right? This one's actually desmoid tumors, progressing desmoid tumors. They were 1-to-1 to receive placebo versus drug, and progression-free survival was the primary endpoint. If you look at it, they hadn't reached progression-free survival in either group yet, but if you look at event-free survival, 76 and 44% right now. Objective response rate, 41%. I always think 8% is kind of close to that placebo effect that we tend to see in most of our oncology trials. And then complete response is 7%. And so this drug's out there, approved, ready to roll. And, I think obviously this is where making sure that we're keeping up with the literature is important. What were the side effects? Diarrhea was number one at 84%, nausea, fatigue, hypophosphatemia, which we see now with some of our FGFR-based therapies, right? So we're getting used to looking at other electrolytes with some of this, and a maculopapular rash. The interesting thing, and this was brought up in a couple different areas, and the review article had additional information about women of childbearing potential. There was ovarian dysfunction identified in some of those women, which speaks to the importance, even with some of these oral agents, even though they're not cytotoxic, making sure that we're counseling on fertility preservation. So about 75% of women had that. It resolved in 20 of the 27 that had it. That still means that there were 7 out of 36 women that ultimately may have trouble conceiving now. So a deeper dive, GIST now has more drugs than I see patients officially, but the interesting thing is there's at least another drug out there looking that's this is one that has a broader TKI exposure, but this was bezuclastinib plus sunitinib together, and this was new, so I just kind of brought this up because it was new. And if you look at it, it was an objective response rate in the second line setting of 33%. I'm going to tell you, even imatinib to begin with, I'm not sure I saw an actual response rate. We saw stable disease in a lot of patients, but to actually see these tumors shrinking, pretty exciting there. Grade 3 toxicity is 38%. And so this is kind of that gastrointestinal stromal tumor story. I kind of highlighted the ones that I thought were interesting. So imatinib up front, unless people have my eyes are too small because I don't remember all these things. The D842V mutation, and remember that avapritinib may be effective in those patients. And so this is kind of one of those times where getting that molecular testing and making sure that we know how the tumor is going to behave. And then I think the other thing that took place is we now have third and fourth line therapies as well, and kind of highlighted the ones that I think are probably most relevant there. And that's ripretinib, that's approved there in fourth line therapy, possibly earlier lines based off of some additional information coming out. So this was one of the ones that I said checkpoint inhibitors have failed. This is probably one of the few where checkpoint inhibitors by themselves have not failed. If you look at alveolar soft part sarcomas, Atezo along with Pembro have both been approved in this setting, and it's really preferred regimens, right? So there are some checkpoint inhibitors starting to filter into some of these earlier. Ooh, I'm 2 over. All right, so sarcoma. Why do we have trouble? It's a wide variety of tumors that can be difficult to differentiate. We know pathologically they can be hard to see. They have markedly different responses to therapy, even sometimes within the same category. They exhibit a high propensity to develop resistance, right? So they respond, and all of a sudden, 2 weeks later, they have growth. And they can de-differentiate with or without therapy, meaning even some of these sarcomas that are well differentiated at the beginning, over time, you give them enough time, something bad will happen. All right. How do we overcome it? Obviously, the multidisciplinary approach was at the top of the NCCN guidelines, and I think that is so important. And as medical oncologist, I'm extremely dependent on 2 groups of people to make sure I'm doing the right thing, and that's pathologists and radiologists. And so having that multidisciplinary team to make sure that you're going after the right tumor type is important, right? Obviously, expertise in that diagnosis with specialized centers, molecular evaluation, and then molecular therapies, clinical trials. I didn't bring up NTRK. I didn't bring up ERBB2 mutations. There are tissue agnostic related, markers and therapies that are out there. And I think it's important that we remember to check these tumors for those as well, because they do exist. There are lots of case reports of NTRK fusion proteins and other things there, right? And another goal, and obviously, is antibody drug conjugates are gaining ground, and there's some interest there as bispecifics and maybe CAR Ts and other things. And last but not least, and not to talk ChatGPT, but there will be more medically related, large language models coming to fruition that are going to be helping general medical oncologists feel more confident going into the room and talking with the patient, so that they're better educated. Because I can tell you, my patients are doing it, and they're coming in with questions. They're coming in with, undergraduate degrees in their disease state sometimes, which is great because we start off at a better point. If it's a disease state I don't know much about, they may be coming in sometimes with more information I have. So, and just in case you didn't know, sarcoma is a yellow ribbon. All right. So, thanks.